what more can we have than this illustrious panel drawn from all the directions that the healthcare needle is moving. We have AMTZ represented by Dr. Jitendra Sharma. Vishal Bali has seen the industry grow in many capacities. Professor Srinath Reddy, illustrious, articulate, and a fine author. His writing style is something that I am very a big fan of. Of course, and a teacher, so happy Teachers Day to you, sir. And of course, Artemis, Ms. Chakravarti, and Dr. Raghuvanshi. Really fortunate that we have some really good speakers here. So I'll start off with the big questions now. We are in a constant beehive, as Dr. Sangeeta Reddy also mentioned. This industry has been evolving, churning in all directions. Talk about a healthcare system which has grown into, like, as she also mentioned, grown in market caps, grown in various contours. How does it function? Let me first go to the extreme right from Dr. Raghuvanshi. Let's hear what he has to say. He's actually spoken quite well on the subject a couple of times in the most recent past. So I'll put it right across to him on exactly what do you think, sir, will be the direction going forward? How can we actually move or probably leap from here?
I think we have come a long way as far as health parameters are concerned. As Dr. Kyani was pointing out, the life expectancy has grown. So as far as public health is concerned, I think India has moved quite a bit in this direction. But what I feel strongly is that many times there's a discourse in India where the private healthcare sector can take care of the needs of our nation. My strong belief is that public healthcare sector has a more important role to play, and private healthcare sector has got its own place. So I think a lot more needs to be done in that direction, but I think overall the ecosystem which is required for a system where there is less wastage is very, very important. And I think in that direction, ABDM and the digitization is very important, so that there is a linearity of record. The illnesses are treated as an individual and not as episodes, and that is what is going to make a lot of difference. So I think we have not committed enough resources to that part, but a good beginning has been made. So I think if that infrastructure is strengthened and that is sort of integrated into every part of the healthcare delivery system, whether it is a preventive care, whether it's a public care, or whether it is the private healthcare systems. So that is what is going to change things.
To you, ma'am, you've spoken about, you have a model, Artemis Light. Do you think that's the way into the future to be between the family physician and the tertiary care sector? That's what I picked up from your presentation.
Yeah, so thank you for this opportunity. And I will come in a minute to our concept of Artemis Light, but on a larger picture of affordability in healthcare, I think for all of us who are medical doctors, it's not just running our own hospitals, running our business centers. It is a desire from the heart of every Indian doctor that any patient who comes to him or her should be treated. And I am glad that this conversation is today coming across both from the public and the private side, because end of the day, we could be running businesses, or we could be running our balance sheets or looking at our market caps. But every time you send a patient back because of lack of affordability, it pains each one of us, and which is a fact. So what do we do to look at it, and how do we create this whole universal health coverage piece? What is it that we can do more? Definitely, like Dr. Raghuvanshi says, that private players have their own place. 80-85% of tertiary care is being catered to by the private. And here I would just take a minute to explain, and which was very beautifully explained by Dr. Girdhar Gyani, that tertiary care is expensive in any part of the world. And I mean, I am a radiologist. We import our MRI, CT scan machines from places like United States, Netherlands, Germany, and wherever else. We pay import duties to get that machines. And in those countries, an MRI is done starting price of 30,000 rupees. Whereas in India, we do it between 5 and 10,000 rupees. So what we are trying to say is, in the private sector, we are also extremely conscious about prices. We are trying to subsidize as far as possible by using economies of scale. But anything which is over-subsidized or free, like Dr. Gyani mentioned, is non-sustainable. So if we really want to cover larger section of society, the underprivileged, and those who are really at the bottom of the pyramid, we will have to think of ways when we can partner with the private sector. Do not make it over-subsidized when nobody is willing to do it. Do it in a manner where there is an accountability. The first thing, which even I think Giridhar Gyani ji had mentioned in the paper, the spend on healthcare has to go up for the public sector, and there has to be an accountability. Where is every penny spent? Then how can we partner with the private sector in a manner which is not only about subsidizing? So in that regard, I would say public-private partnerships are important. Accountable spend by the government is important. And technology and research, extremely important. We have started our own research facility for translational research. Nobody in India, with the type of data set we have, are doing the kind of translational research which is required. Let the drug discovery come from India. Let us not be a me too and copy. Let us create our own patents to bring down the cost of healthcare. And some of us have taken that initiative to start those kind of bench to bedside research. So all of that, combined with tech, combined with research, accountable spend by the government, and a proper public-private relationship which is sustainable, is going to make the universal healthcare a reality. As far as Artemis Light is concerned, this is a model that we had started, where we feel that for everything, you do not have to come to a tertiary hospital, because the cost of running a simple procedure like an endoscopy in a tertiary care is higher, because that's just the nature of the beast. So in a light kind of a model, which is basically a kind of a link between the patient and their family physician, we have tried to create that model with the tech, with lower prices, which now we are seeing a lot of people are coming to it for 80% of their problems, which is basically fever, endoscopies, bronchoscopies, which they are getting done at a fraction of a cost. This is just one of the model for us to bring down the cost, but we have to do a lot more if we are looking at universal health coverage.
Yeah, so you ended exactly where I was going to prod Professor Reddy about universal health coverage. I had this opportunity to hear you in 2012 at an Access conference of OPPI, where you spoke about universal health coverage way before we started the government program in 2012, and then it was 2018. So, sir, at that same event, you had actually given a very nice, proper contours of how it can all be done. Do you think all of that is actually happening right now? What are the missing gaps?
what was then envisaged was a complete architecture of universal health coverage. Several pieces of that are now in place. Certainly, the entire configuration is not there, but I believe we have a fairly good framework in order to advance primary health care on the basis of what Ayushman Bharat currently has. I think having the primary health care piece well positioned, having the hospital cost coverage subsidized substantially by way of PMJ, having digital connectivity to the digital health mission, and an investment in increasing the availability of healthcare facilities to the infrastructure mission. All these are there. But there are several disconnects. There are disconnects, for example, between the primary care and the hospital care, even covered by PMJ. We do not see the continuity of care. We do not see an integrated healthcare system, which digital health could provide. But I think administratively, even the disconnects between the National Health Authority and the National Health Mission, which are still there, do not permit that kind of integration. Secondly, I think there is a lot more that is required in terms of access and affordability. And we do need to bridge those gaps, as the two keynote speakers have said. Let me pick up from where the two keynote speakers have actually emphasized. Sangeeta Reddy spoke about the importance of primary health care. Dr. Girdiyagani pointed out that the availability of hospital beds is rather low, and we need to increase the number of hospital beds. Both are right, but with an aging population, rising burden of non-communicable diseases, increased frequency of hospitalization, while more beds are required, you cannot really meet that requirement over a period of time. It will be an escalating demand unless you invest in primary health care. Much of the disease can be prevented or diagnosed early, managed effectively in primary care, and selectively referred to secondary and tertiary care when needed. Unless that integrated healthcare system is built, we are not going to see universal health coverage coming in at an affordable manner. So that is the very important lesson I think we should draw. Secondly, since this is mostly a private sector audience consisting of hospitals, even though the link to primary care does exist in some cases, like for example, Apollo does have a primary care outreach. But even in the hospital care settings, why are we not being able to adopt greater practices of ambulatory care, of ensuring that we don't necessarily need to hospitalize everybody? But very importantly, one thing that can be done and should be done is building hospital consortia, which can actually do pooled procurement of drugs and equipment. Now, we know that the National Cancer Grid has already published how they have effectively managed to unite about 90+ hospitals across the country and have negotiated for some cancer drugs with almost 88% median cost reduction for cancer drugs. So the private sector, by uniting amongst itself as purchasing consortia, can actually reduce the amount of cost that is levied by the suppliers for drugs, equipment, and pass that benefit on to the patients. So there are very many innovations that can be done even now while waiting for the architecture of universal health coverage to be further strengthened.
Absolute pertinent points. Vishal, to you, you've identified opportunities for the last 10, 15 years. You've seen how, small companies can be grown. You've built scale for them and exactly the need gaps. So oncology, you've invested, you've come out of it. There are maternity, setups that you built. You've spoken about a future where you see probably gastro and pathology labs also. Do you think, and then you also mentioned about requirements in insurance, that has been a big gap. So uh, are you seeing a future where probably all of these things can be achieved? Because, all our three previous speakers identified different, deficits. Where do you think, because you will have an eye on exactly what returns do you get, and exactly in 5-year horizon. So your turn.
Thanks, Vikas. It's always a pleasure to be in your sessions. So let me start with the basics over here. And that is, since we are talking about equitable health, what is the key driver of equitable health all over the world? So I think the third-party payer ecosystem is probably the biggest driver of equitable health. Now, whether it comes from on the primary side, whether it comes on the secondary side, tertiary side, across the healthcare conundrum, I think the third-party payer ecosystem is the one that will take everybody along in terms of overall receiving good healthcare. I think that's an area which probably has not found the last impact. Even today, we have just about close to 40% of Indian households which have some degree of health insurance coverage, which is, so 60% of the people are still ending up paying out of pocket across the healthcare ecosystem. So that just goes to show that where will the affordability come from? If the third-party ecosystem does not really take shape. Now, this I'm not saying from a private lens alone, I'm also saying it from the public lens, right? Because if you look at all the insurance schemes that the various governments, including the central government, have run, the overall coverage in terms of the population is about 240, 250 odd million people out of a total of 1.2, 1.3 billion people, right? So, and the rest of it is coming from the private side. So I think we are hugely underpenetrated in one of the core areas of equitable health. Obviously, and I can't but say about the entire equity side of things, which is where is the capital coming from? And while we are hugely focused in terms of the private enterprises in this country, which are obviously now there is no private enterprise which has not got funded through some external private equity or venture capital fund. India has collectively taken almost close to about $15 odd billion of funding in its healthcare sector over the last 5 years, which is hospitals, diagnostics, only in these two sectors. I'm not even including pharma. So there is tremendous amount of interest, but obviously I think it all boils down to that are we only catering to one segment of the audience over here, or is the healthcare coverage going to go deeper down as we go into beyond the metros into the tier 2 cities of the country? I'm a big believer that I think the future growth trajectory of healthcare enterprises is actually sitting on the tier 2 side of this country. And you know that our own enterprises at AHH are now in 63 cities of India. So I see that there are great opportunities in terms of what we can do in this sector together between the public and the private side. I think there are also massive challenges because I also find constantly that our public ecosystems and our public health insurance systems don't have a long-term run in terms of their own capitalization, right? And otherwise, why would people and why would healthcare enterprises today struggle to receive their money from the Ayushman Bharat scheme? Every second or third day, we find some enterprises, some states getting up and saying that the healthcare providers in that region have stopped taking Ayushman Bharat basically because they don't get their monies on time. So that just goes to show because that it's capitalization through and through, whether it is the public side or whether it is the private side. I think in order to create a good long-term view on healthcare penetration in this country, we need capitalized allocation to be there on both the sides so that the entire ecosystem can grow equally.
So that gap has been largely left out. So that probably will be the next set of questions from my side. So Dr. Sharma, sitting along with healthcare investors, big hospitals, and again, the data is screaming. Is it right that, about 95% of devices used in hospitals are actually imported? And where do you see you are shouldering a huge responsibility of AMTZ? What are the green shoots coming from there?
Firstly, happy Teachers' Day to all the teachers amidst you, including my teacher in the center, Dr. Srinath Reddy. When you sit with him, you always wait for the grace marks that can make you pass. Three things. Taking the lead from Dr. Devlina, you know, there are strengths. I remember Mr. Onkar Singh Kanwar, the chairman of Artemis, proudly, when I was in AIMS 15 years ago, calling us and showing the first pneumatic chute system installation in Artemis Hospital. AIMS didn't have it. Technologies get picked up at various points on the value chain by various players based on their bandwidth and their ability to foresee. And to some extent, private sector does that much faster. But if you look at healthcare as a pie, as a big circle, what are the 4 parts? And let me bisect them and tell you what is in our control, what is not in our control. Part 1 is the real estate, the land, the building, the infrastructure, and that cost will be driven by the real estate industry, not by healthcare industry. So like it or not, you won't have control over it. The second part is the human resource costs. None of us, and I would like to meet a person in this hall who can say that he or she would like to take lesser salary next month than this month. None of us would like to take a lesser salary, which means human resource cost will not come down. Inflation, affordability, ambition, whatever be the cause, human resource cost will not come down. The third cost is the cost of drugs, the pharmaceuticals. Dr. Srinath Reddy and one of our colleagues from PHFI right in 2008 published data, Dr. Shaktivel Selvaraj, on out-of-pocket spending on drugs. 60% out-of-pocket spending that time in 2008 was on pharmaceutical products, right? Drugs and diagnostics. Thankfully, India is a global pharmacy. As Professor Reddy mentioned, National Cancer Grid could negotiate because we were producing it in the first place. We were a global pharmacy. Which means it's already in our control. What is the fourth component of healthcare? If real estate is not in our control, human resource will not be in your control, drugs is already in your control, what is out of control? And that's medical technology. Exactly as Dr. Devlina mentioned. She cannot buy an MRI. She could not have bought an MRI scanner 2 years ago from India. Happy to tell you, AMTZ, my organization, we are an 8-kilometer industrial park. Started with 10,000 rupees on 3rd of January 2018 in the port city of Visakhapatnam, Vizag. Today, we are officially the world's largest medical technology park with 164 factories, 22 centers of Government of India, and 10,000 rupees on 3rd of January 2018. We are today a 16,000 crore cluster. We have 3 factories just for MRI. When I was in health ministry and I would buy a 1.5 Tesla MRI scanner for 6 crore by tender, I am today exporting in 2 crore 80 lakhs, an MRI scanner from India. MRI, CT scan, cath lab, C-arm, X-ray, the entire radiology segment we produce. Heart valve, cardiac stent, pacemaker, cardiac balloon catheter, cath lab, LVAD, we produce. India has made gigantic, as Dr. Sangeeta Reddy was mentioning, moonshots in medtech. And one thing I would implore all of you to consider is, if Vande Bharat train can have a Made in India logo, can your hospital have a Made in India logo? We make it today. Just to make a beginning, we have started the first Made in India hospital in Nagpur, where every single medical equipment from a syringe to an MRI scanner is made in India. And they are all CE US FDA certified. So there is no question of quality. And I think capturing the deadlock that we have had, 96% import dependence, we have brought it down to less than 60% now, and we would be an import neutral country by 2032. Can all of us be partners and brand ambassadors in the medical technology portfolio, which is the fourth uncontrollable, gigantically progressive domain within the healthcare? My second point is very small. When I was in health ministry from 2013 till almost 2017, we rolled out 27 national programs in public-private partnerships, where we said a private hospital can continue to be private in their infrastructure, a public hospital can continue to be publicly operated, a district hospital in its infrastructure, but can the specialized service, like dialysis, be made into public-private partnership? Now, 27 national programs, including the national CT scan program that led to setting up of 850 CT scan centers in 738 districts of India, was only possible, and my friend Ravi Walia is sitting, he would vouch for it. Lal Path Lab, SRL, every single private sector entity became our partner because we brought in private sector to provide specialized service in public sector. The reverse PPP never happened. Jan Aushadhi Kendra, that it gives free subsidized generic medicine, not a single private hospital put a Jan Aushadhi counter. And therefore, as public sector allowed private sector to come in and give specialized service, can private sector bring in public sector to give what is affordable? The RPPP, reverse PPP. And the third point, and that's where I'll close, is if you look at education sector, the primary education is given, it's the duty of the state to provide primary education. And that's where I think Mr. Bali would agree. It's the state's duty to provide the primary part of the care, whether it's education, housing, water, sanitation, or health. And then the top up can be given where technology and investment moves faster. So can we look at an insurance model where the basic insurance for everyone, regardless, just like the UHC cube definition says, regardless of caste, creed, economic status, anything, is provided by the state publicly, and the top up to that care is provided by private sector, either on co-insurance mode or that part on out-of-pocket mode. Certainly there would be moral hazards, certainly there has to be checks and balances, but I think this co-ownership of society between what should be necessarily given by the state, by the public sector, topped up by the industry, is a very unique model that India could explore. Thank you.
Wonderful. Wonderful to hear that, sir. Yeah, and you had a massive runway so far as the medtech zone is concerned and filling up all those gaps. I think it's a very big achievement. So, you know, in medtech, I think the surge is so real. We haven't seen that kind of a thing in the last 10 years, probably. You know, all of those medtech zones are throwing up so many important products. So back to you, Dr. Raghuvanshi. Sir, you mentioned about the requirement of tailored approaches for different population groups. You're already like a massive group, you know, 24,000 people working, 33 hospitals, 5,700 beds. Dr. Reddy, Sangeeta Reddy spoke about the reduction in ALOS from 11 days to 3 days. Do you think, so first, sir, give us kind of a lay of the land of what exactly do you mean by a tailored approach for different population groups. And then you also spoke about preventive side taking a precedence over the curative side.
As far as tailored approach is concerned, I think there are different regions in the country, geographic regions, and where the socio-economic condition varies a lot. So there has to be a solution which is tailored to that particular population, because in terms of infrastructure, availability of human resources, all those things need to be addressed. Now, as far as we are concerned, we look at primary health care as a very, very important part of healthcare delivery. The chronic disease burden is continuously increasing. And unless until that is controlled, the cost of managing the complications is going to be so high that as a nation we won't be able to afford that. So I think that is very important, and you're right that it's partly the responsibility of the government, but at the same time, healthy behaviors also have to be inculcated into the larger society. And the awareness about that at the moment is relatively low in the large part of our society. So urban populations probably are more aware, educated urban people are more aware, the rural population may not be that aware. Yesterday I was traveling at the airport and the security guys were talking among themselves. There was hardly any passengers in the security check, and one of them said that we would bring some sweets, and then the other one said that we can have it because we are young, we don't have sugar. I was quite surprised to hear that. That means there is some degree of awareness which is creeping into every segment, and which is a very, very healthy sign. But I think primary healthcare is an extremely important part of any healthcare delivery system. Just the curative part is going to be so expensive for India. Of course, it needs to be addressed in the present. But a long-term solution is that primary healthcare is strengthened.
So in that direction, would Fortis look at steps in terms of spreading out further? Because as Vishal also mentioned, the real elephant in the room is actually going down deeper into markets which have not been tapped so far.
Yeah. You see, there's so much to be done. We can't really boil the ocean. So we have identified few areas where we want to participate. So one of the area which often gets ignored is mental health. So Fortis has identified that as an area where we want to grow and we want to provide the infrastructure and support. So there we are coming up with a comprehensive service which includes the physical center, availability of psychiatry services, availability of psychological support services, online services which is technology driven. So the entire gamut of services. So that is what an area which we have identified. Other than that, we are also looking at spreading in some of the tier 2, tier 3 cities. Our network in Punjab essentially is in tier 2 cities. We have 6 hospitals over there. So that is the direction we are taking.
Dr. Chakravarti, what will be your approach, so far as, so the whole idea is about how do we ensure equitable healthcare, catching trends early, using AI models, because you are still in that mid-level stage, where you have about 800 beds. There is a very big white space for you. Going forward in terms of opportunities, will those be the areas which you will be wanting to tap?
Yeah, so yes, the opportunities are this. We should be soon coming from Gurgaon to Delhi. We are starting our hospital in Raipur, which is another 500 beds. So taking the bed strengths to almost 2,000 plus by the next 3 years. That is typically the architecture of how corporate hospitals will grow. So apart from that, what we are focusing on, and like Dr. Raghuvanshi mentioned, mental health, which is a very important part for our ecosystem as well. And also what we are looking at is predictive health, which is a part of your preventive health check kind of a program. So personalized preventive health check programs with what we are launching is what is called the Health Kundli, in which you do the next generation sequencing and you understand, and it starts from as early as 35, 40 years and goes on till 80 years to understand what are the type of diseases that you are likely to contact in your lifespan based on your DNA fingerprinting, the next generation sequencing, which we are starting. So predictive health, geriatric health is another thing, because today India is mired by two problems: infectious disease, which was always there, and lifestyle diseases because of growing geriatric population. So we are one of the first hospitals to have launched a very big department of geriatric medicine with remote monitoring for people who are in that geriatric age group, a lot of predictive medicine for them to actually come to the hospital with an illness. So that is another space. Tier 2 cities is definitely what we are looking at, maybe going forward Tier 3. But like I always believe, and people in my panel have mentioned, we should not try and duplicate what the government is doing, but we should complement. If primary and secondary care is their forte, which is, things which we are doing, the Indradhanush program has taken off very well. Immunization of women and children is happening through the government Indradhanush program. The infant mortality rate is coming down, maternal mortality rate. So let the primary and the secondary piece, we can augment, we can help, we can kind of partner, but let that be primarily with the government. The tertiary healthcare piece today, 85% stays with the private healthcare group. Our endeavor should be to make the tertiary care even more affordable, take the tertiary care to areas where it is required, and not try and do everything, because then we won't be able to do justice.
Does that answer a very important question, Professor Reddy? Do you think the spread of tertiary care should actually percolate down to the smaller cities and towns? Anyways, there is so much of crowding in the cities already.
I think the missing piece is the strengthening of the district hospitals. I think that's absolutely critical for us to focus our attention on. Primary care also is not complete. Urban primary health care is not really something that's been attended to even under the National Health Mission. Other than a few municipal corporations, we do not have very strong urban primary health care. And we saw the consequences of that in the COVID pandemic, even where early diagnosis was not possible. And now with increasing urbanization, we need to ensure that our urban primary health care is strengthened. But since tertiary care is very much there in many of the cities, it is the secondary care which is now currently the weak element. And that's why we must ensure that district hospitals are strengthened, and they can even be upgraded to medical college hospitals, as the plan is currently there. But unless we strengthen the secondary care element, there will be that missing link between primary and tertiary. The other element that I think we need to talk about when we're talking about how to make healthcare more affordable is that we cannot only depend upon physicians. There is a great need for technology-enabled allied health professionals at primary care, at secondary care, and to some extent even in tertiary care. We are talking about not only frontline health workers, we are talking about physician assistants, we are talking about technicians. There's a huge need for allied health professional training, and that's where the private sector should start investing in, and co-investing with the government if necessary, where possible. And we have to fill in those gaps as well. But I think the most important element is to connect primary, secondary, and tertiary care in a seamless, bidirectional manner. As long as they exist as separate islands, we're not going to be able to contain the costs, nor can we provide the appropriate care.
Yeah, Visha. So, will you be looking at those areas now? I mean, now that you've already kind of nurtured so many companies at the city levels, do you think that's where you will need to go? And whether you will take some investments from Dr. Sharma's company?
No, so because I'm a big fan of single specialty healthcare, and I believe that if we have to unlock the system in some way, then we have to unlock some of these specialties to come out of the large format multi-specialty institution and create a growth trajectory of their own. I think all our work at AHH has sort of demonstrated what we can potentially do there, because then you also in some way become relevant in some of the tier 2 cities around the country. So, you spoke about how we built oncology, and in fact, in that segment, 90% of the centers that we opened in oncology were all in the tier 2 cities. When I take a look at the motherhood hospitals today, out of the 30 hospitals that we have, 60% of them are in tier 2 cities. In Nova IVF, which now runs 120 IVF centers in the country, 80% are in the tier 2 cities. So effectively, I think when you unlock these specialties, and also AINU, our specialty in urology and nephrology, except for Hyderabad and Chennai, the rest of the hospitals are all in the tier 2 cities. And we are doing equally well, both from the growth perspective and from economics perspective. So I think there is a great opportunity as we unlock these specialties from the large format, because obviously the large format cannot go into many of these cities because the unit economics just don't throw up that effectively. But the moment you go down the single specialty side, you can go into multiple new territories, multiple new geographies, and scale healthcare delivery in those regions. So I think that's one big opportunity that India has. And what we started in 2016 has become like a big phenomenon. But it was very tough to sort of take on that, to build on top of that. And I think that's where a lot of future capital will also begin to flow. So even in last year's overall funding of $8.9 billion, almost $4.5 billion went onto the single specialty side, because India is waking up to its tier 2 cities and the opportunity of healthcare in the tier 2 cities. And obviously, I think the other big one is going to be in the medtech space. Because for the longest period of time, we did not have enough enterprises where we could put capital behind to scale them and grow them with the Make in India stamp on it. But I think that opportunity today represents itself in a very big way. We are seeing some of the early shoots. There are some phenomenally good medtech companies that have come out of India. And I hope that there will be many more which will get that power, because ultimately one part of affordability also sits there, which is how do we create more affordable medtech so that we can go and deploy a lot of that into some of these markets which are not so affording.
I heard the bell ring, but I'll borrow 2 minutes from Garima. Just one conclusion from each of you, very short ones, of what you will do to reduce or probably ensure equitable healthcare. You've already spoken about your contribution, but still, let's start with you. Very short, Chris.
Care systems will remain a function of cost. Affordability for those who are receiving care and viability for those who are providing care. And I think as long as we improve our value chain and domestic production, the viability will keep going up. As long as there is a bilateral exchange of primary care, secondary care, tertiary care, the affordability will keep going up. And I think that's which will drive capital also. And therefore, the point would be convergence as far as possible, and brand ambassadorship of Made in India goods that can really make us the engine.
Tough question for you, Vishal, because you also have to ensure that you get more out of the investments that you make.
Yeah, but I think I would re-emphasize again that I would double up on the opportunity of single specialty healthcare in this country, and I would probably put double our capital into behind these enterprises in multiple tier 2 cities. And secondly, the most important of all, I think, look at new opportunities around new specialties which we can bring to the market and scale to the market.
You have a lot more coming for Professor Reddy.
Well, basically to advocate for bridging the multiple divides that exist now between different levels of healthcare, between public sector and private sector and voluntary sector, between even allopathic medicine and Indian systems of medicine? How can we ensure that all of them can be brought together in a cohesive, complementary manner to provide support for universal health coverage? In short, universal health coverage is not achievable without unified health coverage.
Well said, sir. Ma'am, yours.
One thing I would focus on is translational research, medical translational research. The data produced by India is phenomenal, and the West is borrowing from us and taking great research opportunities out of this. Today we could be the world's pharmacy, but we have to wait for 10 years for a patent to die before we can copy it in generics, right? Medical science is progressing so fast that nobody has time to wait. So if we have to really maintain an edge and be the true pharmacy to the world, we have to develop our own patents. We have already started a complete division of research, translational research, where Indian scientists from all over the world have joined us. As we speak, we have 15 senior scientists, PhD programs. We are, we have associations with international universities, with ICMR. Protocols are being written, funding is happening, and also it is being funded by us as an organization. So we have to start thinking in that direction because we are already sitting on a huge data, and that's the only way we will be moving ahead.
Ma'am, on translational research, I'll go back to something that Professor Reddy had said, again, back in 2012 probably, and he had quoted a Swedish economist. He said, health leaps out of science and draws nourishment from the society around it. I think that probably will make him happy as well.
I would like Dr. Reddy to come and visit our research facility to see what kind of research is actually happening now in India. And I would request all healthcare providers, public or private, to bring that momentum in. The time is right, people are ready to come back. You have to provide them with the infrastructure. Government has to help us with some funding. And we are just an inch away from being the true pharmacy to the world in terms of drug discovery, therapeutic discovery, and things like there is a patent which we have applied for from a thermophilic bacteria from the volcano, which is like the bacteria which thrives in the volcano. That kind of a thermophilic. A protein which has been extracted has shown very great results in Parkinsonism. The tremors go away. It crosses the blood-brain barrier. So, we have filed 5 patents, and there is so much to do. Let us not be just a Me Too or a copycat.
Absolutely.
Because we have the data, and that's what we must focus on, going forward.
That's a bonus. Innovation is not something that I had expected to hear
Because
from
healthcare is
But,
changing
yeah.
every decade, maybe faster. If you're only copying, we will always be behind.
Absolutely.
We have to be ahead of the curve.
That's another long discussion. We'll do that as well. Sir, your turn.
Yeah, I agree with what all has been said, but as personally I would, the idea of the reverse partnership where, the private sector sometimes stays aloof from what the government may be doing, and I think I take that point and I'll try to emulate that in some way or form. The other point I want to make is that data is very good and important and the most important component. So the focus should be on digitization of medical records and the kind of a lifetime journey of patient. That is very, very important, and that completely is in sync with what Dr. Reddy has said. Otherwise, as an island of primary care or secondary or tertiary care, we won't be able to provide the solution we need.
Right. Thank you so much. I think that kind of wraps up this discussion, the inaugural panel. I'm very, very excited about what came out from here. The investment opportunities, the innovation, Professor Reddy's, wisdom, which probably needs another play, and of course, Dr. Raghuvanshi, sitting at the top of a very large hospital chain. A lot can be done from that level. And of course, Dr. Sharma, amazing work happening there. Thank you so much. I think I should also thank you all for being an amazing audience. The house is still full. So